This e-lecture covers chapter 63 in the Lewis textbook, Musculoskeletal Problems. Low back pain is common and has affected about 80% of adults in the U.S. at least once in their life. Backache is second only to headaches as the most common complaint. Low back pain is the leading cause of job-related disability and a major contributor to missed workdays. Low back pain is most often due to a musculoskeletal problem. It may be experienced as localized or diffuse. In localized pain, patients will feel soreness or discomfort when a specific area of the back is palpated. Diffuse pain occurs over a larger area and comes from deep tissue layers. Low back pain can also be described as radicular or referred. And radicular pain is caused by the irritation of a nerve root. It is not typically isolated to a single location, but instead radiates or moves along a nerve distribution. Sciatica is an example of this type of pain. Referred pain is felt or perceived in the lower back, but the source of the pain is in other locations, such as the kidneys. Low back pain is a common problem because the lumbar region bears most of the weight of the body, is a flexible region of the spinal column, contains nerve roots that are at risk for injury, and has a naturally poor biomechanical structure. Jobs that require heavy lifting, vibration, and extended periods of sitting are also associated with back pain. Healthcare personnel who perform direct patient care activities are at high risk for the development of low back pain. Lifting and moving patients, excessive bending or leaning positionings, and frequent twisting can result in low back pain that causes loss of time, loss of productivity, and disability. Acute low back pain is pain that lasts 4 weeks or less. Most acute back pain is caused by trauma or an activity that produces undue stress, such as hyperflexion. Examples of trauma that could cause back pain are heavy lifting, overuse of the back muscles during yard work, or a sports injury. Often symptoms do not appear at the time of injury but develop usually within 24 hours. This is because of the gradual increase in pressure on the nerve from an intervertebral disc and our associated edema. Symptoms may range from muscle aches to shooting or stabbing pain, limited flexibility, range of motion, or the inability to stand. There are few definitive diagnostic abnormalities at present for nerve irritation and muscle strain. One test might be the straight leg raise test. MRIs and CAT scans are generally not done unless trauma or systemic disease is suspected. MRIs are also have limited in the acute phase of an injury due to the increased edema near the site. When you're assessing a patient for acute back pain, you should obtain the following important health information from the patient. This is the subjective data. When you're trying to collect objective data on a patient with back pain, you should focus your assessment findings on these key points. Nursing diagnoses for the patient with back pain may include, but are not limited to, acute pain related to muscle spasms, impaired physical mobility related to pain as evidenced by movement restrictions and muscle spasms, ineffective coping related to effects of acute pain, or ineffective health management. The overall goals are that the patient with acute low back pain will report satisfactory pain level with pain less than 4 on a 10-point scale, demonstrate return to prior level of mobility within prescribed restrictions, demonstrate correct performances of exercises, use coping behaviors effectively to adapt to effects of acute pain, and integrate a program of appropriate posture, body mechanics, exercises, and weight management into daily routines. Use proper body mechanics at all times to serve as a role model. This includes increasing the patient's bed height, bending at the knees, asking for help in lifting and moving patients and using lifting devices. Assess the patient's use of body mechanics and offer advice when the person does activities that could produce back strain. Some healthcare providers refer patients with back pain through a program called Back School. This formal program, usually taught by health professionals such as nurses and physical therapists, is designed to teach the patient how to minimize back pain and avoid repeated episodes of pain. Referral to a physical therapist or personal trainer to address posture as well as core and abdominal strength may also be appropriate. Recommend flat shoes or shoes with low heels and shock-absorbing shoe inserts for women. Advise patients to maintain healthy body weight. Excess body weight places additional stress on the lower back and weakens the abdominal muscles that support the low back. The position assumed while sleeping is also important in preventing low back pain. Advise patients to avoid sleeping in a prone position because it produces excessive lumbar lordosis, placing excessive stress on the lower back. A firm mattress is recommended. Encourage the patient to sleep in a supine or side-lying position with the knees and hips flexed to prevent unnecessary pressure on support muscles, ligaments, and lumbosacral joints. Recommend the use of a firm mattress. Teach patients the importance of smoking cessation, as smoking impairs circulation to the discs and may contribute to low back pain. If the acute muscle spasms and accompanying pain are not severe and unbearable, the patient may be treated as an outpatient with NSAIDs and muscle relaxants. Massage and back manipulation, acupuncture, and the application of cold and hot compresses may help some patients. Severe pain may require a brief course of corticosteroids or opioid analgesics. Some people may need a brief period, 1 to 2 days of rest at home, but should avoid prolonged bed rest. Most patients do better if they continue their regular activities. Patients should refrain from activities that increase the pain, including lifting, bending, twisting, and prolonged sitting. Symptoms of acute low back pain generally improve within 2 weeks and often resolve without treatment. Although exercises are often taught by a physical therapist, reinforce the type and frequency of prescribed exercise and the rationale for the program. The goal of management is to make an episode of acute low back pain an isolated incident. If the lumbosacral area is unstable, repeated episodes are likely. Obesity, poor posture, poor muscle support, age, and trauma may weaken the lumbosacral spine so that it is unable to meet the demands placed on it without strain. Exercise is aimed at strengthening the supporting muscles. Patient teaching is imperative and will be discussed on the next several slides. Persistent use of poor body mechanics may also result in repeated episodes of low back pain. If the strain is work-related, occupational counseling may be needed. Low back pain can cause frustration, pain, and disability. Provide emotional support and understanding care of the patient. Position assumed for sleeping is important in preventing low back pain. Tell patients to avoid sleeping in a prone position because this produces excessive lumbar lordosis, placing excessive stress on the lower back. Advise patients to maintain appropriate body weight, as body weight places an additional stress on the lower back and weakens the abdominal muscles that support the lower back. Begin exercises with 2 or 3 minute warm-up periods by moving arms and legs, alternating relaxing and tightening the muscles. Exercise slowly with smooth movements. Chronic low back pain is pain that lasts more than 3 months or involves repeated incapacitating episode. It is often progressive and the cause can be difficult to determine. Causes include degenerative conditions like arthritis, osteoporosis, weakness from the scar tissue of a prior injury, chronic strain from obesity, pregnancy, or stressful postures on the jaw, and congenital spinal problems. Spinal stenosis is a narrowing of the spinal canal, which contains the spinal cord. Stenosis in the lumbar spine is a common problem causes of chronic low back pain. Stenosis can be caused by an acquired or inherited condition. A common acquired condition is osteoarthritis. Arthritic changes narrow the space around the spinal canal and nerve roots, eventually leading to compression. Inflammation caused by the compression results in pain, weakness, and numbness. Other acquired conditions that may cause spinal stenosis include rheumatoid arthritis, spinal tumors, Paget's disease, and traumatic damage to the vertebral column. Inherited conditions that lead to spinal stenosis include congenital spinal stenosis and scoliosis. The pain associated with lumbar spinal stenosis often starts in the low back and then radiates to the buttock and leg. It is worse with walking or prolonged standing. Numbness, tingling, weakness, and heaviness in the legs and buttocks may also be present. History of decreased pain when the patient bends forwards or sits down is often a sign of spinal stenosis. In most cases, the stenosis slowly progresses. Nursing management and treatment of chronic back pain is similar to the acute pain. Manage the patient's pain and stiffness with mild analgesics such as NSAIDs. It's integral to the daily comfort of the individual with pain. Antidepressants may also help with pain management and sleep problems, as they have secondary side effects that help with this. Sometimes the anticonvulsants, gabapentin or Neurontin, may improve walking and relieve restless leg symptoms. Weight reduction, sufficient rest periods, heat or cold, PT, and exercise and activity throughout the day assist patients in keeping the muscles and joints mobilized and stiff-free. Sometimes cold and damp weather can aggravate the back pain, which can be decreased with rest and local heat application. Complementary and alternative therapies such as biofeedback and acupuncture may also help reduce pain. Minimally invasive treatments such as epidural corticosteroids and implanted devices that deliver pain medication may be used for patients with chronic low back pain that fails to respond to the usual therapeutic options. Surgical interventions may also be indicated in patients with severe chronic low back pain who receive no benefit from conservative care and have continued neurologic deficits. Specific surgical interventions will be discussed after intervertebral disc disease. Intervertebral discs separate the vertebra of the spinal column and helps absorb shock for the spine. In-disc disease involves the deterioration, herniation, and other dysfunction of the intervertebral discs. Disc disorders can affect the cervical, thoracic, and lumbar spine. Degenerative disc disease, or DDD, results from increased wear and tear on the discs with aging. The discs lose their elasticity, flexibility, and shock-absorbing capabilities. Unless it is accompanied by pain, this wear and tear is a normal process. Thinning of the discs occur as the nucleus pulposus, or the gelatinous center of the disc, starts to dry out and shrink. This limits the disc's ability to distribute pressure loads between the vertebrae. The pressure is then transferred to the annulus fibrosus, the strong outside portion of the disc, causing progressive destruction. When the disc is damaged, the nucleus pulposus may seep through a torn or stretched annulus. This is called a herniated disc, a condition in which a spinal disc bulges outward between the vertebrae. This is a visual depicting various stages of degenerative disc disease. The disc can first bulge before herniating. The spinal nerves emerge from the spinal column through an opening between adjacent vertebrae. Herniated discs can press against these nerves, causing what's known as a pinched nerve, causing radiculopathy, which is radiating pain, numbness, tingling, and diminished strength and a range of motion. Osteoarthritis of the spine is associated with DDD, as the stresses placed on the vertebrae can result in osteoarthritis. As the poorly lubricated joints rub against each other, the protective cartilage is damaged and painful bone spurs occur as one of the changes found in osteoarthritis. In lumbar disc disease, the most common manifestations are low back pain, radicular pain that radiates down the buttock and below the knee, along the distribution of the sciatic nerve generally indicates disc herniation. A positive straight leg raising test may indicate nerve root irritation. Back or leg pain may be reproduced by raising the leg and flexing the foot at 90 degrees. Low back pain from other causes may not be accompanied by leg pain. Reflexes may be depressed or absent depending on the spinal nerve root involved. Paresthesia or muscle weakness in the legs, feet, or toes may also occur. Nerve root compressions from a herniated disc tumor or epidural abscess may be marked by severe low back pain, progressive weakness, increased pain, and bowel and bladder incontinence. This condition is a medical emergency that requires surgical decompression to reduce pressure on the nerves. In cervical disc disease, it can radiate into the arms and hands following the pattern of the involved nerve. Similar to lumbar disc disease, reflexes may or may not be present, and the hand grip is often weak. Because manifestations of cervical disc disease may include shoulder pain and dysfunction, the provider must also rule out shoulder disorders as part of the diagnosis. X-rays are done to detect any structural defects. A myelogram, MRI, or CAT scan is helpful in localizing the damaged site. An epidural venogram or discogram may be needed if other diagnostic studies are inconclusive. An EMG of the extremities can be performed to determine the severity of nerve irritation or to rule out other conditions such as peripheral neuropathy. The patient with suspected disc damage is usually managed conservatively. This includes limitation of extremities of spinal movement with a brace or belt, local heat or ice, ultrasound and massage, traction, and a TENS unit. Drug therapy to manage pain includes NSAIDs, corticosteroids, opioids, analgesics, muscle relaxants, anticonvulsants, and maybe antidepressants as adjuvants. Epidural corticosteroid injections may reduce inflammation and relieve acute pain. However, if the underlying cause remains, pain tends to recur. When symptoms subside, the patient should begin back striking exercises twice a day and continue for life. Teach the patient the principles of good body mechanics. Discourage extremes of flexion and torsion. With a conservative treatment plan, most patients heal after 6 months. If conservative treatment is unsuccessful, radiculopathy becomes worse, or loss of bowel or bladder function occurs, surgery may be considered. Surgery for a damaged disc is generally indicated when the patient is in constant pain or has had a persistent neurologic deficit. Laminectomy is a common traditional surgical procedure for lumbar disc disease. It involves the surgical excision of part of the vertebra to access and remove the protruding disc. A hospital stay is typical after the procedure. Discectomy can also be performed to decompress the nerve root. Microsurgical discectomy is a version of the standard procedure. The surgeon uses a microscope for better visualization of the disc and disc space to aid in the removal of the damaged portion. This helps to maintain the bone stability of the spine. Percutaneous discectomy is a safe and effective outpatient surgical procedure. A tube is passed through the retroperitoneal soft tissue to the disc with the aid of fluoroscopy. A laser is then used on the damaged portion of the disc. In this procedure, minimal blood loss occurs because of the access through small stab wounds. The procedure also reduces rehabilitation time. The goal of artificial disc replacement surgery are to restore movement and eliminate pain. The Sherrod disc is used in patients with lumbar disc disease associated with DDD. This artificial disc has a high-density core sandwiched between two chromium end plates. After the damaged disc is removed, this device is surgically placed in the spine, usually through a small incision below the umbilicus. The disc restores movement at the level of the implant. A spinal infusion may be needed if the spine is unstable. The spine is stable by creating an ankylosis or a fusion of the adjacent vertebrae with a bone graft from the patient's fibula or iliac crest, or from a donated cadaver bone. Metal fixation with rods may be placed at the time of spinal surgery to provide more stability. A posterior lumbar fusion may be performed in patients to provide extra support for bone grafting or a prosthetic device. Bone morphogenetic protein, or BMP, a genetically engineered protein, may be used to stimulate bone growth of the graft in spinal fusions. A dissolvable sponge soaked with BMP is implanted into the spine. The protein on the sponge stimulates the body's cells to become active and produce bone. BMP begins the process of fusion, which continues even after the protein and sponge dissolves to leave behind living bone. After vertebral disc surgery, postoperative nursing interventions mainly focus on maintaining proper alignment of the spine until healing has occurred. Depending on the type and extent of surgery and the surgeon's preference, the patient may be able to dangle the legs at the side of the bed, stand or even ambulate the day of surgery. After lumbar fusion, place pillows under the patient's thighs when supine and between the legs when in the side-lying position to provide comfort and ensure alignment. The patient often fears turning or any movement that may increase pain by stressing the surgical area. Reassure the patient that proper technique is being used to maintain body alignment. Enough staff should be available to move the patient without undue pain or strain for the patient or staff. Postoperatively, most patients will require opioids such as morphine, IV, for 24 to 48 hours. PCAs, or patient-controlled analgesia, allow maintenance of optimal analgesic levels and is the preferred method of continuous pain management during this time. Once the patient receives oral fluids, oral drugs such as acetaminophen with codeine, hydrocodone, or oxycodone may be used. Valium may be prescribed in addition for muscle relaxation. Assess and document pain intensity and pain management effectiveness. Because the spinal canal may be entered during surgery, CSF leakage is possible. Immediately report leakage of CSF or cerebrospinal fluid on the dressing, or if the patient complains of severe headache. CSF appears as clear or slightly yellow on the dressing. It should have a high glucose concentration and will be positive for glucose when tested with a dipstick. We should note the amount, color, and characteristics of the drainage. Frequently assess the patient's peripheral neurologic condition after spinal surgery. Movement of the arms and legs and assessment of sensation should at least equal the preoperative status. Paresthesias, numbness, tingling, may not be relieved immediately after surgery. Report any new muscle weakness or paresthesias immediately to the surgeon and document in the patient's record. Assess extremity circulation and neurovascular checks such as skin temperature, capillary refill, and pulses. Paralytic ileus or ilii and interference with bowel function may occur for several days and may manifest as nausea and vomiting, abdominal distension, and constipation. This is partly due to anesthesia or opioids that can slow bowel elimination or gastric motility. Assess if the patient is passing gas and has bowel sounds in all four quadrants or all quadrants. Stool softeners such as docustate cholase and laxatives may prevent and relieve constipation. Emptying the bladder may be difficult due to opioids, anesthesia, and activity restriction. Encourage men to dangle at the side of the bed or stand. If the surgeon allows, have the patient use a bedside commode or ambulate to the bathroom. Ensure privacy. Sometimes, in the event that a patient cannot urinate and they have urinary retention, an intermittent catheterization may be required. Loss of sphincter tone or bladder tone may indicate nerve damage. Monitor for incomplete or difficulty with bowel bladder elimination and immediately report this problems to the surgeon. This may indicate nerve damage. In addition to nursing care appropriate for a patient who has had a laminectomy, other nursing activities are indicated if the patient has also had a spinal fusion. Because a bone graft is usually involved, the postoperative healing time is prolonged compared with a laminectomy. Activity limitations may be needed for an extended time. A rigid orthosis or chair back brace is often used during this period. Some surgeons want patients to be taught to apply and remove the brace by log rolling in bed. Others allow their patients to apply the brace in a sitting or standing position. Verify the surgeon's preferred method before starting this activity. If surgery is done on the cervical spine, be alert for indications of spinal cord edema, such as respiratory distress and a worsening neurologic status of the upper extremities. After surgery, the patient's neck may be immobilized in a soft or hard cervical collar. In addition to the primary surgical site, regularly assess the bone graft donor site. The posterior iliac crest is the most commonly used donor site. Although the fibula may also be used, the donor site usually causes greater pain than the spinal fusion area. The donor site is bandaged with a pressure dressing to prevent excessive bleeding. If the donor site is the fibula, frequent neurovascular assessments, like every hour, of the extremity is postoperatively nursing responsibility. Following spinal fusion, the patient may experience some immobility of the spine at the fusion site. Instruct the patient to use proper body mechanics. Instruct the patient to avoid sitting or standing for prolonged periods. Encourage activities that include walking, lying down, and shifting weight from one foot to the other when standing. Instruct the patient on any lifting restrictions after spinal surgery. Encourage the patient to stop their inactivity before starting any potentially injurious task, such as bending or stooping. Any twisting movement of the spine is contraindicated. Teach the patient to use the thighs and knees rather than the back. Should be used to absorb the shock of activity and movement. A firm mattress or bedboard is essential for these patients.